Welcome to this session. We shall be discussing pre-labor or premature rupture of fetal membrane, otherwise called PROM. My name is Adetunji Oladeni Adeneji. I'm a professor of obstetrics and gynecology at Ladoke Akintola University of Technology, Ogbomoso, Nigeria, and also a consultant obstetrician gynecologist at the Ladoke Akintola University of Technology Teaching Hospital in Ogbomoso. At the end of this session, learners should be able to define pre-labor or premature rupture of fetal membrane, be able to discuss the clinical significance and etiology associated with this condition, the mechanism associated with PROM, the diagnosis including differential diagnosis, the evaluation and methods of confirming PROM, as well as management option. What do we understand as pre-labor or premature rupture of fetal membrane? It defines simply as spontaneous rupture of fetal membrane before the onset of labor. Preterm rupture of membrane can be preterm. Rupture of fetal membrane can be preterm or term. When it is preterm, that means the rupture has occurred after the age of viability and before the gestational age of 37 weeks. Also, there's a terminology that needs to be defined here, and that is the latent period. The latent period is the period, the interval between rupture of fetal membrane and the onset of labor. And also, we need to also understand the concept of the term prolonged rupture of fetal membrane. This is said to occur when rupture of fetal membrane had persisted for more than or equal to 24 hours before the onset of labor. So what are the clinical significance here? It is known that 10% of pregnancy are complicated by PROM, with about 3% having the membrane rupture before 37 weeks gestation. It is also known that 85% of neonatal morbidity and mortality resulting from PROM are due to prematurity associated with it. So in this essence, we need to emphasize that preterm premature rupture of membrane is associated with 30 to 40% of preterm delivery, and it is the leading identifiable cause in this condition. What is the natural history of PROM? Which means when a patient suffers PROM at this moment, how does it proceed? 90% of patients who had PROM enter into spontaneous labor within 24 hours. This particular knowledge is very valuable and vital in the management of PROM, as we shall see in subsequent slides that we'll be discussing. About 50% of preterm patients also experience labor over the same period of 24 hours. So the clinical significance of this will be shown as we go further. So when a woman is diagnosed to have preterm means this rupture of membrane has occurred before 37 weeks of gestation. 70% of preterm patients are in labor within 7 days of rupture of membrane. So what are the risks associated with preterm PROM? The risk vary with etiology, it varies with gestational age, and it also varies with fetal maturity. And these are the factors that will determine how PROM, whether it's term or PROM or preterm PROM, are subsequently managed. There is risk of infection the longer the duration of rupture of membrane before the onset of labor. Said in another word, the longer the latent period associated with PROM, the higher the risk of infection. So, major impact of preterm PROM on pregnancy is that associated with preterm birth and infectious complication. So what are the etiologies? What are those things that have been adduced to occurrence of PROM? The three most common risk factors for preterm PROM or PROM are smoking, previous preterm delivery, vaginal bleeding at any time during the index pregnancy. Other risk factors are previous history of PROM, bacterial infection, either cervical vaginitis or chorioamnitis, or incompetent cervix. Sometimes it is due to the volume of the uterine cavity. It can be overdistension, as can be seen in cases like polyhydramnios or multiple pregnancy. PROM also can be associated with trauma. It can be due to interventions, investigative intervention like amniocentesis, or previous cervical surgery like cervical conization. It is also known that low socioeconomic status, poor nutrition are one of the contributing factors to PROM. And then the institution where an emergency sac-like is done in an incompetent service, PROM is also known to be a common occurrence in this condition. So what are the mechanisms? How does PROM come about? A number of mechanisms have been proposed and quite known and accepted generally are three mechanisms. Number one could be that there is intrinsic weakness of the fetal membrane in itself. And that could be associated with nutrition, can be associated with low socioeconomic factor and all those factors. It could also be, number two, could be mechanical stress. In this case, you have factors like distension, either due to multiple gestation or polyhydramnios. And third, and perhaps very significant, is ascending infection. Let's take this mechanism one by one and discuss what are those things associated with them. In the factors of intrinsic membrane weakness, like I said, poor maternal nutrition, maternal smoking, collagen deficiency syndromes are things that can contribute to this. Zinc as an element, its deficiency had been proven conclusively to be associated with incidence of PROM, because most of the membranes strength are derivable from zinc as a cofactor. Now, in the issues of mechanical stress due to mechanical distension, polyhydramnios, string gestation, incompetent service, and trauma could be classed under these factors. One very prominent common pathway of PROM is the issue of infection. The lower genital tract itself is a potential reservoir for bacteria. We all know about lactobacilli that are present there, which normally are normal commensals. Of course, bacteria and matter neutrophil are able to produce a number of proteolytic enzymes. These are collagenase, elastase, gelatinase. These can ordinarily, in normal situation, will not cause problem. But where you have over proliferation of genital tract bacteria, the increased synthesis and release of this proteolytic enzyme can cause digestion of the collagen, the protein that are the strengthening element of the fetal membrane. And so you can have multiple punctates on the fetal membrane that can coalesce and eventually lead to rupture of fetal membrane. It is also known that when you have proliferation of bacteria, prostaglandin production is higher. Prostaglandin in itself causes uterine contraction. And so, with ruptured contraction, you can have PROM leading to preterm or premature labor and delivery. So how do we diagnose PROM? Majority of patients presenting with PROM have classical history. Either they give you history of sudden gush of fluid coming out per vaginum that now is followed by continuous uncontrollable leakage. Some of them will just tell you about doing their daily chore and suddenly they just had the feeling of the wetness along their private part and the inner part of the thigh, sometimes to the point of the floor being wet. Sometimes many patients have preceding symptoms. Before the rupture of membrane, they have the preceding symptoms of vaginal discharge or pelvic pressure. Occasionally, patients present with equivocal history of either perineal dampness, intermittent leakage, or isolated gush of fluid. Now, this can cause some confusion, especially in those who come with intermittent leakage or they have wetness, because in some conditions in pregnancy, generally in pregnancy there is increased physiological secretion of pregnancy called leukorrhea, but the characteristic differentiating element of this condition is that leukorrhea itself is odorless, is clear or milky, as opposed to amniotic fluid that has characteristic fish-like odor. So sometimes some patients have pathologic discharge associated with vaginitis or cervicitis. In some instances, some patients have urinary incontinence. We know for sure that there is increased progesterone in pregnancy that may weaken the sphincteric control of the urethra or even the bladder. But for this kind of, there is always some preceding history. There may be even exogenous sources, like semen, or in a woman who has done vaginal dialysis. In pregnancy, the fold of the vagina wall is more robust, and semen or even fluid from vaginal dialysis can be entrapped, such that when the patient now goes about the daily chore, the fold straightens out, and some of these can come out and mimic PROM in itself. So how do we evaluate? The initial evaluation of the patient presenting with PROM include meticulous history taking of the duration of this condition of the occurrence. the amount of fluid that had leaked, and whether the symptom itself had continued or abated. A background history of whether there was previous history of vaginal or cervical infection, or the last sexual activity or dowsing is very important in taking history here. Also of importance is history of previous pelvic surgery or inflammatory condition. How now do we diagnose after taking our good history? The diagnosis is usually visual examination of the perineum and detection of typical pungent odor associated with amniotic fluid. Now, one very important and key message in diagnosis of PROM is that digital vaginal examination is excluded until the decision is taken for delivery. So, how do you go about examining? You must do a sterile speculum examination of the vagina and the cervix. The diagnosis is usually confirmed by actual visualization of the fluid passing out from the endocervical canal into the vagina during sterile speculum examination. It is not an examination done on the ward or in the clinic. It is an examination done under very strict sterile condition. Now, in some cases, when you pass your sterile speculum, you might not visibly see pool of liquor, or you might not even see liquor coming out from the cervical canal. So sometimes it is needed to aid by either asking the patient to bear down using Valsalva maneuver, or you put a gentle fundal pressure. This may show you the liquid coming out. Sometimes the next step in confirming that what you really have is from amniotic fluid, or maybe from amniotic fluid, is by doing nitrazine paper test. Nitrazine works with the principle that the pH of the amniotic fluid is 7.0 to 7.5. Let's take this from here. The vaginal environment itself is acidic in the pH range of 4 to 4.5. The amniotic fluid is alkaline in the range of 7 to 7.5. So, nitrazine paper or pH paper uses that, and nitrazine paper turns blue, or litmus paper turns from yellow to blue when you are in an alkaline medium. So if you use nitrazine paper, it will turn blue. And then you can say, what I have here is alkaline, is unlikely to be due to cervicitis or vaginitis. However, there can be some false positive result, because the semen itself is alkaline. So if you have semen or blood contaminating your collection, your nitrazine paper can give you a false positive. So that is why you must take your history to exclude and establish the last coitus act of the patient. Trichomonas infection also can give you false positive. So also is alkaline urine, or the presence of soapy water in the vagina. If it is also possible, one can do what we call fanning test. When a small amount of amniotic fluid is taken from the posterior fornix and put on the slide and allow to air dry, not heat dry, for 10 minutes. And then under microscope, you can watch for fanning. False positive also can occur in this, especially if you have held the slide with your finger. You can actually be looking at your fingerprint on the microscope. So the slide ahead at the edges in taking the sample and smearing, not held on the face. Now, ultrasound can also be done to check the amniotic fluid index, but this is not very, very sensitive and specific, in the sense that the amniotic fluid index has a wide range of 4 to 40. So if you had a woman who had amniotic fluid index of 30 before she ruptures, and then you do your amniotic fluid index by ultrasound and you got 20, you are not sure where she was coming from. But it may point to you, if you have oligohydramnios, conclusively that this membrane had ruptured. The other option you can do is by doing amniocentesis after injection of indigo carmine dye. Indigo carmine dye is a blue colored dye. And when this is done, you put 1 ml of indigo carmine into 9 ml of sterile saline, and under ultrasound guidance, this is injected into the amniotic cavity where the umbilical cord are absent, and then you wash from the vagina or from the cervical canal whether you have a blue dye. Now, it is pointedly to note that you cannot use any other blue dye except indigo carmine. So, this is the procedure. Now, of recent, there is an immunochromatographic assay, trade name Amnisure. And what does Amnisure do? The Amnisure detects a placenta alpha microglobulin 1 protein in the vaginal fluid. This is only present in an amniotic fluid. It can detect up to as low as 5 nanograms per ml. You require speculum examination, and you put a sterile swab into the vagina for 1 minute, and thereafter you put this swab into a solvent in a test tube. It is in this solvent where you have dissolved the sample collected from the posterior fornix that you now put an Amnisure test strip, which is now deep into the vial. Now, the pad region of the test strip contains soluble murine monoclonal antibody to PAMG1. And this is bounded by antigen-antibody reaction. It is in the test region you have a solid phase rabbit anti-mouse antibody that captures PAMG1 antibody complexes. When you have amniotic fluid, that test region turns brown or yellow, and that conclusively shows that the fluid you have tested is amniotic fluid. So you have about 6 different tests that you can use to confirm PROM. Now, there are other adjunctive tests like night blue sulfate stain for vaginal smear. If you use night blue sulfate, the fetal squame stains orange. And that is the only thing that can stain orange under this circumstance. And then you can also conclude that what you have as the fluid in that space is coming from the vagina. There are other tests like vaginal alpha fetoprotein and vaginal oncofetal fibronectin. But these are more for experimental than clinical use. Now, when the diagnosis of membrane rupture is confirmed as speculum examination, one important thing is that you must be able to exclude cord prolapse, because that actually changes the scenario of your subsequent management. Because once the membrane ruptures and there is a cord prolapse, it becomes a dire emergency. I did mention earlier that digital cervical examination should be avoided where possible if patient is not in labor. And it's because it can be associated with increased risk of intrauterine infection unless you are planning to deliver that patient at that time. Now, when you have a PROM, adequate amount of amniotic fluid should be collected at that time to determine fetal maturity. I have said earlier that preterm PROM are also one of the problems, and prematurity and infection is two major complications of PROM. You can also take a swab of the cervicovaginal secretion for microscopic cautions and sensitivity. That helps you in subsequent management and avoidance of endometritis subsequently, even after the patient are delivered, or even chorioamnitis before the patient are delivered while you are waiting. Now, when a woman presents with PROM, it is essential to establish the gestational age because you want to know whether you are dealing with a preterm delivery so that you can take steps towards knowing whether you want to delay, if the woman is not in labor, whether you want to delay to give corticosteroid to enhance pulmonary function, maturity before delivery is conducted. It is important to emphasize here that fetal weight estimation by ultrasound is not affected by oligohydramnios. So certainly, fetal weight estimation and gestational age should be undertaken as much as possible. Now, fetal tachycardia can complicate even PROM, and that could be from infection or even fetal compromise. Where you have cardiotachograph in monitoring labor in PROM, and you have variable fetal heart rate deceleration, which means the pattern is that normally when there is a contraction, there is fetal tachycardia. Subsequently, with the resolution of the contraction, the fetal heart rate comes towards normal. But where you have that even with uterine contraction, you are having fetal heart rate deceleration that are not synchronous with the pattern of uterine contraction, you should suspect umbilical cord compression, which can be a complication associated with a PROM, especially when it is associated with oligohydramnios. Urinary tract infection needs to be also ruled out, especially when you want to conservate a little towards ensuring that lung matures before delivery is taken. Now, what can you do while you are waiting if you decide that, okay, you want to give time to administer corticosteroid? You can do maternal perception of fetal kick count, which is a measure of how well the well-being of the fetus before delivery. Now, what are the management options? At time, it is straightforward. Delivery is the goal. When rupture of fetal membrane occurs before the onset of labor, delivery is the goal. However, we said earlier that 70% of the patients go into spontaneous labor within 12 hours of PROM. So this inform the recommendation that you may need to have a waiting period of about 12 hours after the rupture of membrane, in which you are ensuring that maybe this patient can go into labor, and hoping that the delivery will be fully conducted within the next 12 hours so that you avoid prolonged rupture of membrane. Let me take that again. You have a patient who has had rupture of fetal membrane at this moment, and the gestational age is term. Nobody has done digital vaginal examination, no risk factor for infection, and you have confirmed PROM. You can manage conservatively while awaiting spontaneous labor, because in many instances, PROM occur as a prelude to onset of labor. But however, the waiting period should not exceed PROM, according to American College of O&G. In which case, it is expected that such subsequent labor can be conducted and concluded before 24 hours so that you avoid complication associated with prolonged PROM. In instances when it is preterm PROM, the major consideration and the major factor here is whether you are having a preterm delivery and whether the lung of the baby is mature enough to withstand the stress of outside uterine environment. So below 34 weeks, the strategy may be to delay delivery, administer antibiotics and corticosteroid with the aim of preventing infection and promoting fetal lung maturity. Now, if the gestational age is less than 32 weeks, between 24 and 32 weeks, there is a proven benefit of giving prophylactic magnesium sulfate, which can also act as your tocolytics and also act as neuroprotective for the fetus, because one of the complications of preterm delivery is cerebral palsy that is associated with it. Magnesium sulfate have been proven to be neuroprotective if used between gestational age of 24 and 32 weeks. So how do you go about? You admit the patient to line-in ward. No digital vaginal examination, that is after confirmation of PROM. She's on bed rest. You check vital signs 4 hourly. That is the pulse, the blood pressure, the temperature. You undertake fetal kick count. You ask the patient for abdominal pain and examine for abdominal tenderness. These are to rule out the occurrence of infection process, either chorioamnitis in this case. You monitor the fetal heart tone at least twice a day and put in perineal pad, which you inspect twice a day for color, the intensity of the drain, so that you are able to follow up whether there is an infection going on or whether the PROM is increasing or is worsening. You can also monitor by you measuring abdominal gap at the level of the umbilicus daily, and you will be able to gauge whether the abdominal gap is decreasing or is remaining stagnant. Decreasing abdominal gap taken at the same point may suggest that you are having continuous PROM. You can do CTG and ultrasound twice weekly, biophysical profile once a week, and repeat white blood cell count and C-reactive protein. In some instances, it's been known that resealing of rupture of membrane can occur, but it's rare. When it occurs, it occurs in a condition called hind water leak. Hind water, that means the leakage is not at the most dependent part of the fetal membrane, but higher up. And maybe the amniotic fluid are receded below the point of rupture, and so it has stopped. Now, antibiotic therapy, like I said, is prophylactic. And it is recommended that you can use ampicillin or erythromycin. Erythromycin actually is one of the drugs of choice. However, amoxicillin-clavulanate combination is not encouraged. Is not encouraged in the prophylactic management of PROM. Corticosteroid is given for lung maturity for PROM, preterm PROM, before 34 weeks. After 34 weeks, there is no benefit in using corticosteroid. Tocolytic is towards ensuring that either you are transferring the patient to a better facility to manage for delivery or for you to administer corticosteroid. I've mentioned the fact that you can use magnesium sulfate for fetal neuroprotection between 24 weeks and 32 weeks. The prognosis here is chorioamnitis, pulmonary hyperplasia. Those are the major factors that you want to. The presence of severe oligohydramnios, amniotic fluid less than 2 centimeters, prolonged latent phase, latent period greater than 14 days, and early gestational age at PROM is associated with dismal prognosis. Most importantly, PROM has been a condition that is associated with infection and prematurity, and managed very well. Understanding all the physiology, pathology, etiology involved in PROM, we should be able to give a woman a good product that makes the life of the woman very good, that makes the woman happy as well as her family. Thank you very much.